Hello, welcome all. Coming on to the new sessions of the Antegrade CTO Academy. So, Antegrade CTO Academy will discuss about the coronary wires. What are the techniques of antegrade wire escalation? What are the different type of wires? What are the microcatheters? And we will also discuss the case-based approach towards dealing the CTO in the antegrade manner. So, first to start with, I would be this discussing mainly about the antigrade wire escalation. So, antigrade CTO, this is a global CTO algorithm in which we can see that first of all, a dual injection should be taken and careful analysis of angiogram should be done. And if there is proximal cap ambiguity, then of course we have to take a different route. That is, we have to see if there is a branch, if side branch is present, then we should do the IVAS guided puncture. And if there is no branch, then move the cap approach is usually done. And coming on back to the proximal cap ambiguity, if it is not there, that means if you are getting a clear cut stump, then we should see whether poor distal vessel quality is there. If no, that means good vessel quality is there. Then we should think about the antegrade wire escalation. And if this fails, that means we should gradually change our wire according to the tip load and according to whether they are polymer jacketed, non-polymer jacketed, whether the tip is tapered or non-tapered. That I will discuss in detail in just coming slides. And if antegrade wire fails, wire escalation fails, then this parallel wire or intravascular assistance should be taken, or ADR. I think ADR should be the last resort because it can compromise the branches, that is antegrade dissection and re-entry. And if again it fails and if we don't have a good intervenist collateral, then we can of course leave the patient as an investment procedure and can take up. So this is the latest algorithm by given in the latest paper, good paper, Eurointervention 2023. This is the various ways. First and most important is the bilateral injection to see the distal vessel quality as well as the connection of the collateral coming from the opposite vessel. And first, we should try the antegrade wire escalation. If it is not possible, and if there are some features, then move the cab approach or the IVAS guidance for a stumpless CTO can be used. And if not, then of course, this antegrade dissection re-entry by Stingray assisted ADR can be done. And if it is not possible, then we can go with the retrograde approach, and that I have discussed in the retrograde CTO Academy, how to approach a CTO in a retrograde manner. So the most important thing, or what we can say, the backbone of a CTO opening antegradely is the antegrade wire escalation. So in this particular picture, you can see what are the three most important thing that we can analyze. So if we are going from the CTO uh, through across the CTO body from the proximal cap to the distal, this is called as AWE, antegrade wire escalation. So we should also keep in mind what is the terminology. And if we are unable to get through it, then of course ADR, that means from the lumen we go to the subintimal space, then again we reach the distal to a lumen. So this is called as antegrade dissection and re-entry. And if it is not possible, then we can go from the retrograde. This is RWE, that is from distal cap to CTO body to proximal lumen. This is called as RWE, retrograde wire escalation. And I've discussed that in this retrograde CTO Academy. And for retrograde also, many times we need to go by doing the subintimal dissection, either in the form of knuckle wire or by other balloon. This is called as RDR, retrograde dissection reentry. So this is how the terminology is, and we should keep in mind while dealing the CTO. For the beginners, uh, actually CTO is exhaustive topic, or it's a procedure requiring skills. So the first and the foremost thing that should come in our mind is DPS. And what I say as a mnemonic is Delhi Public School. So D stands for drilling, P stands for penetration, S stands for sliding. So most importantly, we should see what this JCTO score is, that I will discuss in the coming slides. And we should see whether we can make the way by drilling, by penetration, or by sliding. So sliding means we are suspecting we can expect few channels, micro channel that are 100 to 200 micrometer in diameter, and we can think that this soft hydrophilic wire with taper tip can slide through it. The first important thing is that we have to do always is to take a soft wire, that is hydrophilic wire, with maybe a taper tip that is more favorable, and we should try the sliding across the CTO segment. And if it is not possible, and we can see if the CTO's body is hard, then many times we need to drill the CTO. And if it is a short segment and containing calcium, then of course penetration by the needle tip wires like Conquest Pro is the best strategy. So this is again coming on to this, what these three methods mean. So first important, I said DPS, that is trailing, penetration, sliding. So first is sliding. So in the picture shown above, top of these two pictures is sliding technique. So we can see a fresh thrombus or a newly occluded vessel, or we can see the clear-cut microchannels. And if we take a tip hydrophilic wire, like filter XT or filter XTR, then it can go across these collaterals, this microchannels. And if we can see, if it is a bit calcific, then of course the penetration with the hardwire would be needed. And with this picture, we can see if it is a fibrous plaque and it is hard, then of course, so many times drilling would be required by the moderate to high stiffness wires. Few basics taking and while taking the injection, bilateral injection, first you should introduce the right guide, then the right guide for the right femoral, we should take right guide, left femoral, we should take the left guide, and inject the donor vessel first and wait for the dye to clear. So this is how the process of the antegrade wire escalation is. In this, first we have to look that how to take the wire to the CDO segment. We should take a microcatheter, and inside that we should take a normal wire, a workhorse wire like a run through or Scion blue, and bend the 2 to 3 millimeter of the tip at 60 to 70 degree. And over this, we can take the microcatheter near the CTO, this proximal segment or proximal CTO, and proximal part of the CTO, and then reaching the proximal cap. There we can take out the wire and we can take the delegate CTO wire. And the CTO wire should not be more than 1 millimeter tip, and they should be around 30-degree bent. So in the stage one or phase one, we can say the penetration of, we can see the left side of the figure now, it is a CTO showing the stage one penetration of the proximal cap or the micro channel tracking. So sliding comes here because we are not sure whether it is a fresh CTO or old CTO many times. And if the micro channels are there about 200 micron, then the taper T wires, hydrophilic wires can cross. So filter FC wire, filter XTR. So these are the wire we can use, and many times they can go from the proximal calf of the CTO to the CTO body to the distal lumen. But and it is the stage two where we have to cross the intimal, that is the intimal tracking of the CTO body, and third is the penetration of the distal cap and advance to the true lumen. So there can be few variation that CTO body can be a bit hard. Many times we need to escalate the wire. Escalation of the wire means we have to increase the tip load of the wire. This is called escalation, and de-escalation means downgrading the wire. We have to resort to the low tip load wires or the soft wires once we are through the body of the CTO. So combining this various stages. So once we are doing the micro channel tracking, we should use a very low tip load polymer jacketed wires. And in the middle part of the CTO, we should do the loose tissue tracking with the low tip polymer jacketed wire. So there are islands of the soft tissues in between the CTO segments. So that can be easily tracked. That is called as loose tissue tracking. Many times when we come across a hard part of the CTO, then of course the escalation of the wire with the high tip load wires like Gaia 3, which has 4.5 gram tip load, or Gaia Next, which is recently available. And if it is calcific, then we can of course go with the Conquest Pro. So this is escalation of the wire according to the morphology of the CTO body and the distal cap. And once we are through this, then we have to de-escalate, because the hard tip wires can lead to an end perforation, and that are very unpredictable to manage. so very difficult, and they have unpredictable core. So we have to prevent this end wire perforation at every cost, and we have to de-escalate the wire from the higher tip load to lower tip load. And many times it may further require re-escalation because we may through some segment, but if still we find some problem, then of course we can go ahead with the further re-escalation. So this is how the thing goes. So, after discussing these various stages, drilling, penetration, sliding, so we have to keep in mind which wire to be used at which place. So, for micro channel crossing, that is the sliding technique, we have to take this hydrophilic polymer jacketed taper tip wire that is filter XT or XTR or XTA, so generally used to track a micro channel. And many times when the vessel course is not known, then of course we can take a non-tapered, but again a hydrophilic tip that is Pilot 200 or Gladius Mongo that is recently available by Asahi Intact. So this we can use the wires that are hydrophilic, but the tip is not tapered. That when we don't know the vessel course, then of course these wires are preferred. And once we can see that if the vessel course is smaller or well understood, then penetrative tip wire, that is Gaia wire, Gaia 2, Gaia 3, 0 to 6. So these are the wires which have a penetrative tip and can be used to penetrate. And if we see if we have a very calcified segment, short segment, then of course a highly penetrative tip that is Confianza Pro or Conquest Pro wires 12, 18. Or many times they're also used for a scratch and go technique when there's a proximal cap ambiguity. But mostly this scratch and go should be avoided because this can cause the perforation, larger dissections. So mainly highly penetrative tip wires, Confianza Pro, are used to assess to be used in the patient who have this calcified CTO segment. So this is the four types of wire that should be in our mind while we are dealing with the anti-grade wire escalation. So just a few words about drilling. So whenever we are drilling, the most important thing is that the wire should not be moved more than 90-degree in each direction. That means total 180-degree rotation can be given, and moderate stiffness wire like 3 to 6 gram Gaia or UB3, that is ultimate bronze 3 wire, can be used. And the non-polymer jacketed like ultimate bronze 3 or miracle 6, as they have a better tactile feeling, though non-hydrophilic wires have a better tactile feeling, so they can be used in the drilling to drill the hard part of the body of the CTO. And penetration is sometimes needed. In this we can use the guide wire which have a tip which has a more tip load, and this guide wire is used as a needle to penetrate the occlusion, and this is mainly for the calcified short occlusion when the vessel course is well understood. In this Gaia 3 Confianza Pro wires are the good wires that we often use. So first important is the crossing of the proximal cap, then navigating through the CDO, that leads to escalation, de-escalation. And then again, the third part is the distal entry into the true lumen. A microcatheter is advanced close to the distal cap, and a highly steerable wire, that is Gaia series, is directed towards the true lumen. Nowadays, we also got a Gladius Mongo, Gladius MG wire that is can be easily directed towards the lumen because it has a micro gap at the tip, and it takes direction from the subintima to the lumen. And occasionally, stiffer wire may be needed to puncture calcium distal cap, and at this moment, a contralateral injection is a must and it should be taken. So, the characteristic of wire that should be in our mind while dealing with this, whether I am using a soft polymer jacketed wire, that is filter XT wire or fighter wire, a stiff tapered wire that have a composite core, the Shiontech core being the Gaia 2 wire, Confianza Pro, non-tapered wire, that is Ultimate Bros 3, and there are some stiff polymer jacketed, although they are not having the tapered tip. So it is differentiated from the filter XT series that their tip is not tapered when the vessel course is ambiguous, where we can use the Gladius MG or Gladius Mongo or the Pilot 200. So again, just for the basic revision and just to reinforce the things. So what are the soft taper tip wire, polymer jacketed wire, filter XT, filter XTA, a stiff polymer jacketed Pilot 200 Gladius, and a stiff composite core wire that is non-tapered is Ultimate Bros 3 and tapered is Gaia 1, 2, 3. They are stiff composite core wires. So this was all about a few just initiating the Antegrade wire escalation, and in the next session of this Antegrade CTO Academy, I would be discussing about the wires individually. Thank you all for the patient listening.